is what we're going to go deeper into in the first part of this talk.
Good. Okay, so the next thing I want to just share is by our learning objectives. So we hope by the end of this session, you have the opportunity to apply evidence-based teaching strategies to engage learners in discussions around stigma and the treatment of substance abuse disorders, and identify some common learner misconceptions about substance abuse disorders and implement some instructional techniques to address that bias that we talked about and build some of that empathy. And then we're also going to touch on how to integrate substance abuse topics into existing curricula that you might already be teaching, and how you might use active learning or case-based teaching and things of that nature to incorporate this topic. And also, how do we facilitate psychologically safe learning environments that encourage dialogue about anything that is stigmatizing or sensitive in nature, and then to adapt teaching approaches to diverse learner needs and promote cultural humility when discussing substance abuse disorders. So that is a lot. So I'm going to turn it now over to Dr. Yamaguchi to talk about some common learner misconceptions.
Yeah, thank you. So we're going to start with, like I was saying, actually touching on a lot of what you folks have already brought to this, which is a lot of the hurdle when teaching about substance use disorder. You might start conceptualizing it by starting with where the students are at. If you could go to the next slide, Dr. Terrell. So let's go ahead and put some responses to this question in the chat, or go ahead and unmute yourself. But what have you observed about how your learners respond to substance use disorder cases? What have you seen? And maybe it's just emotions.
My experience, if it's okay to speak now,
Please.
yeah, is that people have a lot of baggage when you talk about substance use disorders and people with them, because um, to a greater or lesser degree, almost everybody knows somebody, either immediate family or close friend, who's suffered this, and they have observed them, and they have certain ideas about what they think as people with SUDs, what it is, and what they should do. So there's a tremendous amount of bias, which
Yes.
makes it difficult for them to hear what you're saying.
Yeah, absolutely. It's a hurdle. It's a hurdle to getting the message across. Dr. Fast put in lack of internal language to describe affects. Yeah, that's so true. The discomfort itself can be a real barrier to self-reflection, moving past that. And Dr. Fortuna mentioned frustration. Do you have an example of that, Dr. Fortuna, seeing frustration in a student?
Yeah, I mean, some of this is a little while back, but when I've had students where sometimes we might have an opportunity to see someone longitudinally, at least for a few sessions, feeling frustrated that maybe the person has not followed through with care that maybe we thought would be ideal, and relapses seeming really frustrating, feeling, so sometimes, we've had to process thoughts like, what can you really do anyways, right? In terms of for the patient, if they're not willing, to do it for themselves. And that becomes an important part of conversation, right? About the nature of addiction.
Yeah, I appreciate that. And I'll add to this my own um, experience that hasn't been touched on yet. In working with residents, I mostly focus on college mental health. So I see a lot of college students. So my residents see those students. I think in large part because it's so near peer, this, the residents' age and then the age of the college students that they're seeing as patients. Um, And then just a general um, uh, appreciation for cannabis use. I have noticed in my residents perhaps a um, eagerness to downplay or minimize the significance of cannabis use amongst our patients out of an interest to maybe appear, cool or to seemingly partner with their patients. And it has gotten to a point where even a resident really argued with me about an ADHD management plan in the context of daily cannabis use, feeling like it was not an issue. So I've had, the bias about like patients who are using substances, having the bias against them, but then also bias, it kind of almost in favor or not in favor, but I think you understand what I'm saying. It clouds judgment essentially and obstructs an evidence-based treatment plan. So here are some examples of emotional reactions learners may have. You might be seeing frustration, like what we just talked about. You might be seeing bias, might be seeing helplessness, anger, fear, even. Um, so the next few slides, I'm going to talk about various misconceptions that you might see amongst your learners. And then for some of these, we'll also discuss ways to address it in the learning environment. So one of the more common learner misconceptions is that medications for opioid use disorder, or even more broadly, medication-assisted therapy, MAT, merely substitute one addiction for another. Obviously we understand as the educators that, or we may have a misunderstanding as well, but we understand that MAT is an effective treatment and has been shown to reduce mortality and improve patient outcomes. But when there is this misconception, it can get in the way of students recommending MAT as part of their treatment plan. Okay, and then the next misconception that learners may have is that patients with substance use disorders are inherently untrustworthy or manipulative. I think we touched on this a little bit. Right, it's a common stereotype that individuals with substance use disorders are deceitful, and that leads a suspicious air to their clinical interactions. And this can lead to, again, just kind of truncated care, poor management plans, and just strained and dissatisfactory patient-provider relationships. Educational interventions have been shown to reduce these stigmatizing attitudes among medical students, so that's the good news. So let's apply this to a possible realistic learning scenario. So let's say that during a lecture that you're giving, a resident uses the term drug abuser to describe a patient case. The other learners in the lecture don't react and the conversation moves on. As the lecturer, how might you address this? And go ahead to put it, you can put it in the chat or just unmute yourself.
I think it's an opportunity to clarify terminology if you want, and discuss a little bit substance use disorder and appropriate terminology, which then leads to appropriate management down the line. You mentioned something, and I try to raise my hand, but I don't know. I think Zoom changed again all the buttons. So,
Oh, I apologize.
You mentioned initially, oh, they may be seen as drug seeking. well, they are seeking for the drugs that they are dependent, right? So this is a disease, and they would do sometimes whatever it takes to have another dose of narcotic or benzodiazepine because they are addicted and dependent to it. So yes, they are in a way drug seeking, but because they have this condition, right? It's a natural reaction if you think about the pathophysiology of drug addiction, right? They're gonna find a way to get their drug, right? And it may be a little deceiving, like you mentioned in their behavior may be a little deceiving, but it's part of the disease, really. That behavior is part of the disease.
Mm. Oh, I can't see myself. Oh,
Go ahead, Dr.
sorry
Bowman.
about that. I was looking for myself. Yeah, so in the middle of a lecture, one says, oh, he or she or they are just a drug abuser. I think that I'd say let's talk about that was a term that was used derogatorily and it carries a heavy stigma. And so when we think about the brain and we think about what is dependence, we can discuss that. And we can talk about what an addiction is. We have gambling addiction, sex addiction. We have all kinds of addictions. And these are conditions. This is a chronic condition, a chronic illness that needs to be treated. So that is a very negative term to say to a person. Would you say a diabetic is a sugar abuser? So that word just doesn't have a place for us in the way we talk about our patients. And of course, depending on your audience and how aggressive or assertive the resident gets or the crowd gets, it's fine. So you have to just roll with it, I think, but you really have to bring that into the focus that is a really negative stigmatizing term. Not a good way to talk to your patients about a person who has a chronic condition.
Thank you. Anyone else have anything they want to add?
I mean,
Sorry, I don't know why my video makes me upset, but that's.
Oh, Dr. Porsche, I can't hear you very well.
Oh, let's see. Can you hear me now?
Yes, better.
Okay, sorry. I was just gonna say, like, one of the approaches is, teaching I've taught a lot of courses on cross-cultural mental health and things like that. And it's like there is always a little bit of a fine line between, there's some people who are just not knowledgeable. And I don't want to, also, I think about face saving. So some of the things I might do is kind of repeatedly use terminology I'd like them to use. And in some ways, it's a little bit of, oh, you're right, somebody with substance use disorder, like kind of pulling them along, but it really depends on the person. So it's more about really being sensitive to who you're talking to invite them along. And then the other thing I just wanted to say, when you talk about bias, like, in qualitative research, we do kind of a um, self-reflection on who we are and how that might bias our interpretations when we're doing analysis. I almost might want to do that with teaching about substance use, where I might say, this is not something I want to see. You don't have to share it, but you might take some time to think about where you're coming from and how that might bias what you do, and then move on. But it's just like more of that, that kind of that take time for that self-reflection.
Yeah, that's great. Thank you, Dr. Porsche. So yeah, in our notes for our suggestions on how you might handle this case, you guys have hit them all. So great job. Which is a couple of you have mentioned person first language, which is that idea of, a patient with alcohol use disorder versus an alcoholic patient. So same sort of thing, and doing the modeling of using that inclusive terminology. Okay, let's move on to the next misconception that we often see in learners,
Uh,
which
Before we do that,
oh, sorry.
Dr. Fortuna had her unmiked, so I don't know if you wanted to add something.
Oh, yeah, very minimal. I mean, what Dr. Portia is saying, I agree. I mean, what I might even use in that reflection piece that she was saying is, there's bias and also our own, this is very psychiatry-ish, like our own responses and reactions to a patient, right? And what might be playing out there in our own experiences and our own exposures that might have us react to someone in an automatic way, right? I mean, think about countertransference and all that other stuff like that, right? If we want to get psychodynamic, but even just a simple, like, there's things in our experiences that we need to reflect on that would have an impact on how we might see a patient. And it might be substance use disorders in a very particular way and other things, but we have our own reactions. I mean, in terms of that bias reflection.
Yeah. I just was going to add what Dr. Fortuna and Dr. Porsch made a comment. It's interesting because you prefaced your comment by saying this is a very, psychodynamic, and you were using that. Now, what's really interesting here is I'm thinking about it as I'm having my own experience with this, because I've worked very hard to get addiction into primary care for years now. And so in the primary care world, right, the residents are sitting in front of computers and they're talking about patients, and they're talking about, what this case, that case, they call them cases instead of the people. And then the talk of, oh yeah, they're a drug seeker, they're a drug abuser, this and that. And so I think in a sense, my reaction, and I would certainly not call out that resident in that sense, but I would say it, I usually will frame things as, so let's take a step back and let's think about how we speak about this topic. It's interesting because that terminology is used so often by attendings, by the residents, and it crosses all specialties. Perhaps not psychiatry, but it's so ugly, and it's really terrible. And it gets even in our in baskets. Oh, there they go. They're a drug abuser. That's why they're asking for their pain medicine.
Yeah, thank you for that. So the next learner
And
misconception.
if I can just say
sorry.
documentation is a big thing that we should think about too, Dr. Willett. You're right. Yep.
Yeah, that's a good point. The next misconception I wanted to go over is that relapse signifies treatment failure. And I think we might have touched on this a little bit, but as we know, when I was in my addiction rotation, I learned that it takes an average of 7 times for someone to quit nicotine. And that's an average. So uh, I was really surprised when I learned that. But in my addiction rotation, it became very clear to me, patient after patient, how much relapse is part of the normal trajectory of treatment and recovery. And some learners do view relapse as a failure of treatment or some moral failing on the part of the patient. So let's apply this to a vignette. So let's say you're in clinic and a student tells you privately that they feel uncomfortable working with patients who have substance use disorder because they, quote, always relapse and, quote, don't seem to care. So how might you as the educator address this?
Ray Glenrange here. It's like the Wright brothers. They failed several times before they got the plane that flew. Yes, it's important to just draw that distinction that the default of somebody with a substance use disorder is to use. So the fact that they remain sober is not the natural course of the disease. And the goal is to get them into a state of not being succumbing to what they're supposed to do. And for several people with SUDs, when they relapse, many times their brain is tricked into thinking that they weren't really that bad, and they can use it responsibly from here on out. And it takes them a few times of relapsing to understand I can't do that. So at the same time, reinforcing that this is not that these are bad people or uncaring. They're just dejected that they can't, beat this.
Appreciate that. Thank you. Dr. Bullock, were you going to say
Thank you.
something?
Oh,
I think
yeah.
having some data. Oh, sorry. I don't know.
No, go ahead, Dr. Paul.
These hands don't raise like they used to. So I'm sorry, Dr. Bollard, please go ahead.
Oh, okay. What I was going to first say to this group is often the teaching was that alcohol, cannabis, you name it, meth was often utilized because we have co-occurring disease, right? So we know that it hits people that have mental health issues, or if they have be it depression, anxiety, whatnot, the childhood trauma, things that happen to them. So oftentimes what I would say is in this, the word I say in medicine and in most of life, always and never, I'd like us to really rethink that. And when one has not necessarily made the choice, or the life has been so chaotic and they've gotten themselves involved in methamphetamine as an example. All right, that's a bad example because there's good studies, but not great stuff. Let's take opioids for a moment. And you think, or alcohol. Life became so chaotic for them. And the way they've learned to deal with the stressors in their lives is to mask it. They have these cravings. Remember, let's go back to the brain. And it's not about caring. It's they care deeply. So celebrate with them when they have the sobriety, even if it's short-lived. But that's what I want you to try to take away is people do care and they're coming to us for help. So we need to celebrate their sobriety and help them understand that relapsing is part of their disease. It's their brain. And that is, that's the way I think I would talk to the student.
Thank you. Dr. Popa?
Yeah. Piggybacking a little bit on what Dr. Bolat mentioned, I think this is a discussion with a trainee and we're trying to train them, right? First, we have to be trained to do that and know our stuff, but it's really explaining the disease, having the data that some of it you mentioned that I didn't know about the average of 7 relapses before somebody, becomes successful. So all that is important information. Like we discussed about heart failure and we discussed about studies and evidence and why this medicine works better than the other. I think it's the same conversation that we should have about this disease like we do for any other disease. And I think our level of knowledge and training is not always up to par like with the other diseases because it's been a little bit of stigma and difficult to deal with. You mentioned very early, and I was trying to find the hand sign, so I didn't have a chance to mention it then. But these are difficult cases in the very fast-paced clinical environment that we all work in and train our students and residents. These are the cases that take a little longer, and it's frustrating because I want to move quickly. The hospital tells me I have to discharge, 50% of my patients before 11 o'clock. And my employer says, now you have to see 20 patients. Oh, wait a second, you have to see 25 patients in a day. So then these are, the straightforward case that is a pyelonephritis or something, and that goes fast. So I've liked that case, right, as a student, as a resident. And I don't like the case where there's a lot of back and forth and a lot of maybe failure sometimes, relapses. So I think it's a little bit the training environment that has changed significantly in the last 10, 15, 20 years that is creating an extra challenge to a challenging problem.
Yeah, I appreciate that perspective. Okay, great.
I would add one thing, just briefly.
Please.
as I've sat here listening to everyone, which, I think everyone's making excellent points, and then looking at the vignette, the student is saying, I'm uncomfortable working with patients who have substance use disorder. And the thing that came to my mind was, who is that? Right? Is it a person who's unhoused, who's using meth? Is it a 75-year-old who has alcohol use disorder and has been sober for 5 years, right? And maybe is having, risk of relapse because of a loss. I mean, what I'm saying is it's sort of stereotyping who is a person with substance use disorder that's uncomfortable. And I'd love to have a conversation of that, sort of opening up that it's a lot broader than, who you might have in your mind.
I'd like to echo that too as well. When I saw that last phrase, you don't seem to care. Well, first of all, you need to look at your own countertransference, just like Dr. Fortuna just said. Okay, that's one thing right there. Because what else are you looking at? And the other thing is, and this happened several years ago with a student. It was a very similar situation, and it's they always relapse and they don't seem to care. Well, what if you passed? What if you failed your boards 3 times in a row? You know, what a person, are you going to stop trying? No, because you really, really care about the outcome. So if you keep showing up, you're demonstrating to me that you really, really care.
That's a really good example. Thanks for sharing that. Okay, so let's move on to the next one. And this one is something that Dr. Fast brought up earlier in our talk, which is a misconception that learners may have that substance use disorders are solely the result of poor choices, not medical conditions. And, for what we want to teach, we want to focus really on the interplay of the biology, the psychology, and environmental factors, right? So going to, again, a possible real scenario. Let's say you are leading a small group and a learner expresses sympathy for patients with cancer, but frustration with patients with opioid use disorder, saying, quote, they did this to themselves. How might you, as the group leader, address this?
I would ask the learner to research that hypothesis and see if there is any genetic components to that.
Yeah.
First you have to understand why people feel this way. Universally, people are sympathetic to those with cancer. They didn't necessarily do anything to bring it on with certain exceptions. And there's an end of life potentially scenario, and the family wants to rally around them, and they're very appreciative. With person with SUD is just the opposite. They burn every bridge going down, and they're very prickly, and it's not a good experience for those that have any interaction with them. Particularly healthcare providers. So it's hard to be sympathetic, and part of their mindset that they do this to themselves is just their bias, because they're frustrated with them. And what you have to do is bring them back around to the idea that this is indeed a disease just like cancer or diabetes, that it needs a different approach that's very patient and understanding.
Mhm.
And I think we have to look at, what people do to themselves, quote unquote. There's a lot of smokers who never develop lung cancer. There's people with lung cancer who have never smoked. There's a lot of people who have tried drugs and alcohol. Probably the vast majority of people have at least tried each of these substances at some time in their life, but the majority of people do not become addicts. I remember a screening question they would ask if somebody's to see if they're a substance use disorder patient is, when was your first drink, or when was your first use of a drug? most people cannot tell you. The drug addict or alcoholic can tell you exactly when their first was because it provided a biologically, physiologically useful alteration of their state, which already gets at the physiology and biology that we need to direct our learners to, that produce substance use disorders. It's not the choice, it's the inability not to choose.
Thank you so much for that, everyone. So in our recommendations, we thought about a discussion on empathy gaps, structural determinants of health, and what several of you have discussed, which is disease framing, talking about how we think about disease and this being a disease. I think a couple people referred to diabetes. I think that's a great example for that disease framing. I think for the
Can I add something? I know I'm a non-physician in the room, but it's my understanding from some of the reading I've done that some people become addicted to opioids because they had a sports injury where they were given pain medications and then became addicted. So this idea that they did it to themselves, maybe that needs to be examined too. Just, what caused this to happen? The addiction itself, as you've talked about, is a physiological one, but the idea that not everybody who gets addicted to opioids, went out on the street and bought them. They got them prescribed to them. Anyway, I know I'm not a physician, but I just wanted to
Well,
add.
Dr. Terrell, I was going to say that when I was thinking about this, and because it was opioid use disorder, I think I would have brought home 2 points from, when we think about our own practice. I like to teach that when I'm talking to the residents. I'll say, something like, in 2012, we were asked to prescribe freely for chronic pain for just about anything. And you were considered not a good doctor if you didn't provide patients with opioids. And then, there was a company, Purdue Pharmaceuticals, and a doctor over at Beth Israel who said, by the way, this oxycodone is not, and I mean not addictive. And then we had the 2017 opioid epidemic. So who did it to whom? So this is a fine balance between the fast metabolizer with chronic pain that you think is escalating or taking these more than 50 morphine milligram equivalents. And now what we have to do as physicians, we have to take care, I think, of our patients. And I love the psychiatry group because I'm going to learn from you about all of these things, about really reframing I could have added to that discussion. And I think the other point I would have made is I would have reflected on something. I said, I did a program I started in the state of California for injured workers, the majority of which were people of color, people that were really having challenges, and they had to go through opioid or detox because there was no doctor that was going to prescribe for them. So people don't do it to themselves. I got injured on the job and somebody prescribed it poorly. So much, Dr. Terrell. Great. I second your point.
Thank you. And I'm going to jump back in here and take the next section, which has more to do with the teaching. I'll just share one personal example if I can before I move on. And that's when my husband was suffering from back pain and eventually had surgery. His doctor told him, he put him on Vicodin and said, take as many as you need to feel better. And then we found out later, of course, that can cause liver damage and other things. That was terrible advice. And fortunate, well, one of the things that happened is he had his surgery. He felt instantly better and suddenly became he's a very soft-spoken, gentle guy, if you've ever met him. And became this like angry person, and we couldn't figure out what was going on. And then we realized he was going through drug withdrawals because he'd been popping those Vicodin like they were M&Ms. So yeah, fortunately he was able to get off of them. But yeah, it does raise the question of who did it to whom, as you were saying. So I want to talk, though, a little bit about teaching through the lens of empathy and inclusion and applying some of the elements that you are already very familiar with, which is trauma-informed care, while we apply some of those same principles to trauma-informed education. So let's look at again how those principles apply. So we've got all these different issues, and I have them in separate slides. I think I meant to delete this slide to just do the individual ones. But the first one, of course, is safety. So do we make efforts to create an atmosphere that is respectful of the need for psychological safety among our learners? Now we're talking respect and acceptance in both individual and group interactions, including feeling safe to learn from your mistakes. So the person who says, gee, these drug addicts, I don't want to deal with them, we need to teach around that point, but also in a way that makes that learner feel comfortable making that mistake. And then the next one is trustworthiness and transparency, enhanced by making expectations clear, ensuring consistency in the way we practice our teaching, maintaining appropriate boundaries so that I always say this when I'm talking about other types of teaching, and it applies equally and even maybe more importantly here, which is trust doesn't happen by magic. It happens over time, and it has to be explicitly created. It's not something, and I know I'm preaching to the choir because most of you are psychiatrists. I have to tell you that it takes time to build that kind of relationship with someone. Well, the same thing's true with your students that you would also be looking at with your patients. And the next principle of trauma-informed education, say if we take these from, again, trauma-informed care, which is support. So connecting individuals with appropriate peer and professional resources to help them succeed academically, personally, and professionally. So if somebody reveals that one of the reasons they have problems with substance abuse disorder is because they had a parent who was violent, who was a substance user. Well, maybe there are some resources then that we could point that person to help them address some of those issues in their own life, because that's what I said earlier, is sometimes these conversations can be triggering for people who have personal experience and sometimes very traumatic experiences with dealing with an individual who had a substance abuse disorder, a parent or a friend or anyone in their life. So the next principle is collaboration and mutuality, sorry. Opportunities exist to provide input, to share decisions, and to share the authority and power of the teacher-learner relationship. And I know I said this before, but especially when students are getting into like year 4 and they're moving into residency, part of our job as educators is to move them from the role of learner into the role of colleague. And it doesn't happen overnight. It's a slow process, but we have to be always thinking about how are we moving them more towards that place where they're sharing now in the decision making and the management, patient management, acting like colleagues and allies rather than as teacher and learner, and working, for common goals, like what do we do that's in the patient interest, and using patient-centered care as a teaching method as well, of bringing it back to how do we help this individual, how do we help this person. And then the next principle is empowerment, voice, and choice. So, empowering students to make choices, to develop confidence, to develop competence in dealing with some of these issues. Again, it doesn't happen by magic and it doesn't happen overnight. And also cultural, historical, and gender issues is the next principle. So individuals and groups striving to be responsive to historical, cultural, and gender issues in order to respect one another's diverse experiences and identities. I like to tell my own students that everyone is an expert of their own experience. So I'm not the only expert in the room. Everybody's an expert of their own experience. And you may have experiences that are totally dissimilar to mine, and you likely do. So the last one is resilience growth and change. So emphasizing over deficiencies and pathology. So, trying to provide feedback to convey optimism and facilitate a growth mindset around the fact that people can and have changed. It is possible to see recovery because we know that it does happen. So, an optimistic point of view. So, going back, so the sense of safety was the first principle that we talked about. And safety is a baseline for learning. If we're poised for a threat, whether that's real or imagined, our systems are built to scan and prepare for that threat. So it takes, higher order thinking takes a back seat to personal safety because it's that fight or flight syndrome, right? If I feel attacked, the first thing I'm going to do is put up the walls. And that is not a place where you can learn. That is a place where you're just now protecting yourself. So any kind of unsafe learning environment is a barrier to teaching and learning. And all learners in that environment will be harmed, but they're particularly damaging to any learner who has a traumatic history. And trauma strips away our basic sense of safety and being at home in our bodies. So creating safe and welcoming classroom environments, whether it's classroom, clinical, or lab, that benefits everybody in that learning environment. So again, some questions to think about is, do your students feel safe in that learning environment? Do you? Are you consistently and clearly communicating any safety concerns that might be existing to the proper leadership within, so if it's an issue of safety within a particular clerkship, are you talking to your clerkship directors around that? If it's a classroom environment, are you talking to the deans and associate deans about what's going on? So, we can make assumptions about our students' perceptions of safety, but we know that we can also just ask them. Have you surveyed your students about how they feel? That's the students should not be required or expected to disclose personal issues within a learning environment. They might. Sometimes they're very open. I've had students tell me things my own sisters wouldn't have told me. So some of them, it's a generational thing. Some of them are really open, but not everyone is. So, they shouldn't have to disclose traumatic backgrounds to get a safe learning environment. So be mindful of how you talk to your students about safety. Let students know that disclosure is their choice. Respect their privacy, just as you would want to respect a patient's privacy. And consider that concept of safety varies for different populations and even within those populations. So what it takes for a white privileged individual to feel safe might be very different than what a person of color or a person with an underrepresented group from an underrepresented group or a historically marginalized group might feel very different about their sense of safety within that environment. So if you're from a non-minoritized population, it's up to you to continue to educate yourself and listen to the needs of those communities. I think that's also part of cultural awareness and cultural humility. So work with your students at the very beginning, whether it's a rotation or classroom environment, to set some guidelines about what is and isn't okay within your learning environment. And there's a lot of education research on this, but setting norms, whether it's a classroom norm or learning environment norm, goes a long way to addressing some of these safety issues. Some of the issues of, abusive language and things like that can be nipped in the bud by having that conversation. When I'm teaching a class, I always come in with the first thing I ask the students is, what norms do you want? And then as we're writing them on the board, I say, well, I'm going to add this one. So I get mine in there. But I want first them to say, and often their norms are even more restrictive than mine. So they want a safe environment too. They want an environment where they feel like they're not going to be pounced on if they say the wrong thing. So make it clear to students how, when, and why they can contact you to report any concerning incidents. So, including those that might arise from something that you inadvertently did without meaning to. So, how would they go about addressing that? How would they go about reporting that? This is even more prickly in a clinical environment because there's lots of anonymous ways of reporting in a classroom. When there are 80 people in the classroom, it's difficult for a faculty member to know who it was that said that they had done something, problematic. But in a clerkship, there may only be a couple students, so it's a lot easier to identify who the complainer was. So they're a lot more nervous about reporting incidences like that. So again, can students learn without trusting their teacher or each other? Possibly. But certainly, as we know, a trustworthy environment is much more efficient in supporting the teaching and learning process, in addition to being trauma aware. People who've experienced significant trauma are often hesitant to trust other people. They might be particularly wary of trusting authority figures who they may feel have failed them in the past. So working to earn and keep our trust of our learners, again, is a very important part of this trauma-informed education model. So, how do we create that trusting and collaborative relationship with our students? One way is you can reveal some things of yourself, that you're a fellow human, right? Sometimes work so hard, and I've seen this changes as people age. That when people start teaching and they're almost the same age as the students, they work really hard to try to set themselves apart from the students, say, I'm the authority in the classroom. And the older you get, the more you want to go the other direction. It's like, really, I'm just one of you, right? So it's definitely changes as someone ages in their teaching. But, there's a Michelle Pacansky-Brock, who's very well published in teaching and learning. She has a model of humanizing. That's an excellent guide, and I can provide that if you'd like after the workshop. So again, trust rests on truth. The truth is often uncomfortable, sometimes extraordinarily uncomfortable, but tell it anyway. Tell it to yourself, tell it to your colleagues, tell it to your leadership, and tell it to your learners. Make telling the truth a rigorous, serious, daily practice in your teaching. It's not always easy, and sometimes there might be pushback. Students might feel like you're being too hard on them. That is just focus. We can be, when you're providing feedback, you can be honest with students about their areas of opportunity without belittling or embarrassing them. You can be truthful without being abusive. So focus on their strengths, be kind and be direct and be encouraging, but you should leave, good feedback should leave the student hopeful and motivated, not discouraged. But being afraid to tell the truth because you don't want it to get a bad student evaluation, that's not fair to your students. It's not fair to the patients that they will be serving. So it includes being transparent, also includes having healthy boundaries. So clear, consistent professional boundaries, it's important. And it's, again, these are skills you already have in abundance because you have to set boundaries with your patients, right? And sometimes patients cross those boundary lines. Sometimes students do. I used to ask people in my workshops whether it's okay to date a student who's about your same age. And my answer would always be no, because no matter what, there's still a power differential there. And there's a professional boundary there that can't be crossed. When I was in graduate student, one of the professors was dating one of the other graduate students in the program, and they eventually got married, and they're still married today. So it does happen. But would I recommend it? No, I would always say there has to be some kind of professional line that you don't cross. And, it includes also being transparent in your decisions. Why did you decide a certain thing? Let the students, what I say, behind the curtain, it's like the Wizard of Oz. You're back there. Don't be afraid to expose that. And especially if you make a mistake, name it, admit it, apologize for it, make it right. I mean, and again, you're a human being. You're showing humanness because because if you make a mistake, we all make mistakes, right? So, and then move on. So you are an expert in your field. You have valuable information to share with your students. That's a given. You're a leader in your course or your clerkship. And it's true that your learners know things that you don't know. And they're also potential leaders in your clerkship or course if you create a space for them to step into that role. I'm always blown away by how much students can bring to the equation. I know I learn more from them than they ever learn from me. That's my feeling as an educator all the time. So it's imperative that you think about ways that you can have learners working with their peers and leading themselves and leading one another and pulling on that leadership role a little bit. So, begin the course with or the clerkship with some time for learners to connect with one another. And that might not be a lot of time. I realize in the clinical environment, you don't sometimes have the luxury of tons of time to, go out and do team building activities or whatever. But you can take a few minutes to get people to introduce themselves and get to know each other a little. So prioritize connections over other elements of that introduction to your course or your clerkship. Because a lot of the things that we spend time on when we're introducing a course or introducing our learners to our learning environment, a lot of those things can sometimes be delivered in other formats. Do you really need to spend an hour in your course going over every detail of your syllabus? I mean, they have a copy of it, right? So there's really no need to waste your time doing those things when there's so many more important things you could be doing. So, encourage learners to find and exchange contact information. And this was with a caveat. In a safe manner. We had a situation at a former institution where a student was harassing another student because the instructor had passed around a sheet in the classroom and asked everybody to put their email address and phone number on that sheet. So again, what I always would tell my students is if like I'm putting them in a group and that group's going to work together for the entire semester, share any contact information that you're comfortable sharing. So if they have a separate email account that they use or something of that nature, I would never ask a student to give another student their cell phone. Now, if they feel comfortable doing it, that's fine by me. But I think that, you have to unfortunately think about how some of that openness can be problematic down the line. So, and have, again, encourage but don't require your learners to maybe find a buddy who they're going to exchange contact information with. You want to especially be aware of students that might be prone to feeling isolated within the learning environment and whether or not you choose to tackle any kind of formal group activities, just get them to work with their peers as much as you can. And then next, the old model, as we know, of higher education teaching was that of sage on the stage, it's called. The professor might have even stood behind an actual podium and communicating that sense of distance and separation between themselves and their learners. They were the only leader in the classroom, and the students were often seen and treated as beneath them. So most educators, fortunately, have moved away from that rigidly hierarchical model towards a more collaborative, learner-centered approach. So again, we want to reflect on your philosophy of education. To paraphrase Yeats, do you see teaching as the filling of a bucket or the lighting of a fire? Or perhaps learning is the creation of a space for learners' existing fires to burn more brightly. So review your course and your note places or your clerkship where students can have input on what they want to learn, can have some kind of empowerment within the learning environment. It doesn't mean that they get, that a first year block one student knows everything they need to know. I mean, it really depends on the level of the learner and how much agency you can afford to give them. But you need to think about where those places are where you can afford to give students a little agency. And, model and teach in teams. model that. Ask learners to share their own learning goals, especially helpful in a clinical environment. What is it that they hope to walk away with on this rotation? As I know I've talked about before, sometimes I hear, well, I can't do anything with the learners that come on my rotation because they're not interested in fill in the blank, pediatrics, OBGYN. So they don't want to be there. They don't want to learn anything. And there's nothing I can do about that. My argument is it's your job to do something about that. It's your job to try to show them what they can learn. And I know you all know, that they can learn so much from any rotation, even if that is not the specialty they end up in. There's still so much to learn. So again, teach the learners how, when, and why to advocate for themselves. Some people have said the pendulum swung too far the other way, and now learners are trying to drive the curriculum, and that is that there may be some truth to that. So that's why, again, it's a question of boundaries, right? Where can you afford to give a little flexibility, and where do you need to hold firm and say, nope, this is curriculum we must cover. This is very important, and this is why. Rethink again that dichotomy, just rethink the teacher learner relationship and how it's working. So the next one of my favorite teaching quotes comes from Thomas Carruthers, which is up here on the slide. A teacher is one who makes himself progressively unnecessary. We can help our learners find and use their voices to speak truth to power, to become more confident in thinkers, creators, citizens, physicians. People who've experienced trauma were often in situations where their rights and their choices were taken away from them. So trauma-aware learning environments also empower students. So balancing your choice with your structure. Again, I think I've made that point already. If you're new to trying to use trauma-informed educational principles, start small. Pick one or two things that you might try. You don't need to overwhelm yourself or your learners with all kinds of new things. You can just kind of think about, maybe here's one tweak I can make. And, scaffold by offering a most popular choice option. So again, for less confident learners, this lets them make a choice, but provides them with more structure. So I teach undergraduates, so obviously it's different than teaching medical students or residents. But with my major projects, I usually have, a sort of laundry list. Pick among these things. And I find, especially because I'm teaching freshmen, it's their very first quarter on campus, that's saying, okay, you make up your own final project. They just panic. I mean, they're not ready for that, right? So if you say, here's some possibilities that you might choose from, it gives them the agency to make a selection without giving them the terrifying role of having to teach the class for themselves. So create spaces for all voices in the classroom. Again, this is something we talk about when we talk about inclusive teaching and learning and living. It's messy. So I always love to say to my students when they say, this is really hard, I always say, you say that like it's a bad thing, because learning is messy. We're going to make mistakes. You're not learning if you never make a mistake. That means you're not stretching yourself, you're not growing, you're not developing new skills. Part of doing that is, messing up and learning from that experience. Most of us know that we learn a lot. Sometimes we learn more from the mistakes we made from the things that we did that came easily. And then if you wish to be trauma aware in your teacher, you have to acknowledge, all forms of racism, misogyny, ableism, bigotry towards LGBTQ plus folks. To deny any form of oppression is an example of an opportunity to re-traumatize the individual. So you're not asked to be perfect. Often we're going to make a mistake. I always tell people I suffer from foot and mouth disease. I know I probably said things that were inappropriate to people. The idea is you're just being asked to keep trying, and you're just trying to be more aware and just keep you know, it's iterative. You just keep moving towards that goal. You're never going to reach it entirely. No one can say, okay, now I'm done. I am completely aware of all the issues that might happen, you know, but you're just trying to reflect and have greater awareness. So you're also, you know, asked to think about your own privilege and act to dismantle that privilege. So you're asked to think and feel deeply about how trauma impacts different people differently. So there's a tension here because trauma doesn't care how much money or privilege we have. Anyone can experience trauma. That said, money, privilege, and power also do protect some people from some types of trauma. Both of those things can be true at the same time. Someone could have a very appearingly privileged environment that they grew up in, and it still might have been a violent home. It might have had all sorts of problems that don't always show on the outside. So again, do your own work. Seek out existing resources on all types of oppression and bigotry. I was in a workshop once where someone was critical of the idea that, you know, people from marginalized groups shouldn't always have to represent that group and be educating others on what they need to know. And she said, well, if I don't ask, how am I going to learn? And I didn't say this at the time because I wasn't doing the workshop. I was just in it. And I thought, yeah, it's too bad there aren't any books or anything on racism, right? There's nothing out there that you could use to educate yourself, right? So there's tons of resources out there. Consider incorporating discussions of race into your teaching. So, does your institution have space for you to talk about your experiences with some of these issues with other educators? You know, recognize that sometimes resilience can be used to ask trauma survivors to practice a sort of chin up mentality. Like, you know, you're a survivor, you're so resilient. It's like, you know, that can sometimes backfire. So that can lead to a sense of re-traumatization. So it's not bad enough I had this experience, but now I have to, you know, just soldier on anyway. You know, so you know, trauma is sometimes something that by definition is unbearable. So we do have community and university resources that can help students who are dealing with some of these issues, and we want to be aware of that. So this is a long list, and our time and energy are limited. So we just have to develop practices that we can sustain. We can't fill from an empty cup. We have to be aware of our own limitations. So, you know, when I read, I might underline some ideas, but some ideas just jump off the page, and those will get some other type of annotation next to them, like a big exclamation point, you know. So I'm going to share with you this trauma-aware checklist, much of which I've just talked about. And I asked Nen if she could put the links in the chat. I don't know if she has the ability. I scanned the QR codes. There it is. Perfect, Nena, perfect timing. And the, you know, I have it, I just covered a shorter version of this list, but I gave you the handout and, you know, just glance through it and see if there are certain things that just immediately pop for you. That can be a very useful tool. So how are we doing on time? We're getting a little low on time. So I'm gonna skip ahead and I'm gonna ask Dr. Yamaguchi to jump back in to talk about ways in which we can integrate topics across the curriculum.
Okay, great. So we are going to do an activity here. And it's a small group activity to get participation moving again. We'll break up into small groups for 5 minutes and have everyone discuss these 3 questions. 1, identify one place in your current teaching where you could integrate substance use disorder content. 2, select one teaching strategy you can use. Maybe it's a trauma-aware teaching strategy. Maybe it's one of the ones we discussed in the first bit of this talk to address learner misconceptions. Number 3, determine one way to check for learner understanding. All right, so I'm gonna need some help with doing the groups. Dr. Tiro?
I'm sorry, I was just asking how many groups. It looks like we can go with 4. Is that okay?
Yeah.
All right. There we go. You should be getting an invite now to join a room. And I just want to say, if you really don't want to join a room, just hang here for 5 minutes. Please don't just leave the session.
Okay, great. So why don't we start with having each group talk about what they talked about. We'll start with my group. Dr. Nguyen, would you be able to discuss what we talked about?
Yes, Dr. Yamaguchi. So we talked about working with med students, the rising M3s and the M4s who have had the clinical experience under their belt in working in different clinics. But again, the nature of the discussion and the depth will depend on the experience and the comfort of the students who want to discuss the various issues of substance use and the complexities thereof. And I work with students from CUSM and also from Loma Linda. And in each of these settings, you have variations in terms of backgrounds, in terms of different types of substance use and the severity of the substance use disorder, be it alcohol use disorder, cannabis, or inhalants. And Dr. Yamaguchi and I were discussing on how we can support the learners and also be a part of the learning process.
Thank you so much. Is there another group that wants to go? I'm not familiar with who's in which group.
Well, I know Dr. Woods and Hawkins were both in the same room together, so maybe one of you could share. I accidentally closed the room, so I can't actually tell you exactly who was in which room, but I know the 2 of them were in a room together.
Yeah, we can go ahead and do that. We didn't know anything. We came in late, so we were just sitting there, just kind of chatting with each other. So we really didn't understand. We didn't have the questions with us. So me and Hawkins just winged it. He's one of our third-year medical students going into emergency medicine. But I can answer one of the questions. How am I going to be able to kind of incorporate substance use disorders, into what I'm doing as a psychiatrist and what I'm doing as a teacher too as well? Well, I'd give a PowerPoint presentation to the patients about gender dysphoria or gender incongruence now is the correct term for it too as well. And there's a slide in there where I talk about sexually transmitted infections because they can be really, really high in the LGBTQ plus population, especially in the trans and gender expansive population. So as a result of kind of doing this, what I'm going to do is help because half the new cases of HIV involve methamphetamine usage. One of the things that I can do and incorporate that in my list of questions is do you exchange do you exchange sex for money or drugs or methamphetamine? So I think that's something that will be an additional question that I'll put in my PowerPoint presentation. Hope that helps.
That's great. Thank you. I know Hawkins well. He was my summer intern and research intern and has worked with me on a paper we're trying to get published. So uh, I I wanted just if there's another group that wants to jump in, but we do want to move on because we're almost out of time. And I do have a handout, and I'll put the link in the chat for it. It's this integration handout that can also just be a tool to think about, like, uh, how can I put some of those tools together? And if it's all right with you, Dr. Yamaguchi, I'm going to jump into the closing just because we're sort of running out of time and I want to make sure we allow a few minutes for questions. So I think that, again, one of the things to think about is what is it that you want your learners to be able to remember or feel when you are teaching about substance abuse disorder. So this is, and I'll just leave you with that thought. We can, you know, that's that backwards design thing that I talked about when we talk about curriculum design. It's like, think about what it is that you're hoping that they'll walk away with when you're planning that. So again, we talked about some of these issues. We ran out a little bit of time, but I want to share with you that our next session is not until September, and that one is on bridging cultures, strategies for inclusive teaching in SUD. And if I'm not very much mistaken, I think Dr. Woods is going to be joining
Yes.
me and co-teaching that session. So I'm really looking forward to working with you on that. And then we have the remaining sessions, so you might want to mark your calendars. The following sessions are all here, and they're on in November, January, and March. And before we run out of time, I also want to say that we are in the active recruiting stage for the Teaching Excellence Academy. And if you're not familiar with what that is, it's the flagship program of the Office of Faculty Development. And we've had many people, some of them who are in this room, have gone through this program. And it is a competitive program, so you have to be nominated and you have to apply and you have to be chosen by a committee. But it has been an enormously successful program. In all the years that we've done it, only one person dropped out, and he asked if he could rejoin this year. It was a conflict health issue with his partner. So that it's unheard of in faculty development to have a longitudinal program that people don't just say, enough of this. So it's been a really successful program. If you want more information, please, please, please contact me. And now I'm going to just leave it open for questions. And I just want to say again, I know that time is one of your most precious resources. I'm really appreciative that you spent some time with us. I do have some references I'm happy to provide in a more legible form, and I'm going to stop sharing so that people can ask questions if they would like.
I'll just jump in and say that, I had tech issues, other people did, the things that come up, we plan to do these things, then we can't do them. And so the live programming is all helpful, but a really complete resource library with the handouts, the references, the whatever documents that you were planning on sharing, and the audio recordings. I mean, just all of it, so that in a time discontinuous way we can access it, download it, store it on our own files, et cetera, et cetera. Especially for people like me who I'm clinical faculty, and so if there would be something that would be naturally shared on a Riverside server or SharePoint, well, I don't really use those. So to have you feed us stuff in a way that's retrievable on our time would be really helpful for me as a learner in this process.
That's a great suggestion. And yes, we're happy to provide all of that. And I can put everything that we shared tonight and even a couple slides we didn't get to and some other content into a Google Doc and a Google Drive so that you can get it whether you're behind our firewalls or not. And I'm happy to do that. So thank you for that suggestion.
Great.
Okay,
And I'm sorry if there were technical issues. I thought I had broadcast all the questions to the rooms. Did you not get that broadcast?
No, we didn't get it.
No.
Yeah.
So
And
sorry
if-
about that.
And if I could say something, if you look on the chat, there's our post
Mhm.
survey, post-session survey
Yes.
that we do as part of our SAMHSA funding. So if you could do that, that would be wonderful, because that's how we continue to show our progress and keep Samsa happy and continue to fund our initiative. So if you could do that, there's a QR, not QRS, that's something else. QR code that you can do.
QR code. And we can,
Yes.
we'll follow up with an email too and include the link and the content
Yeah.
in an email as well.
Thank you.
Any other questions or concerns? I also want to, I would be very remiss if I didn't also thank Dr. Yamaguchi for partnering on this session and doing such an amazing job working with me when we weren't 100% sure that you were going to be available because
Yeah, because my
when
maternity
are you
is coming
due?
up July 22nd.
So, so we're glad you made it and thank you. And
Yeah,
again, if
thank
there
you,
aren't any
Dr.
other questions, just thank you all again very much for attending tonight. And I'm happy to hang if anybody has questions. And I'm sure Dr. Yamaguchi can hang for a few more minutes, but I believe we actually are out of time. So have a lovely evening, everyone.
Rosemary, I'm gonna
Thank
hang
you.
for a second. Rosemary, I'll hang for a second.
Sure.
Yeah, it was weird. I saved an email that announced this, and then I went in and I clicked on the links, and it took me to a file. And I don't know what, I thought, what the hell is that? And the file wouldn't open. And I just couldn't get anywhere. And I gave up. And then at 30 minutes in, one of the staff sent an email, maybe a blast to all of us and said, we heard you guys are having trouble getting in, get in this way. And it was, instantaneously easy. But everything I was trying before was just like not working. And I didn't even understand what I was looking at. I would click on it. It certainly wasn't a Zoom link. It took me to a file to download. And so I downloaded the same file like 8 times. Every time I clicked on it, the same thing happened and nothing. It was just weird. And so there was something in what was sent out and the way it was formatted that it didn't allow me to access it at all. And so whoever, I think it was a coincidence, it was totally unrelated to my issue. I think was that somebody said, we hear you guys are having trouble, and then they gave us a easy to use link. So I don't know if I could explain it better, but that's what happened.
No, you explained it perfectly well. I'm really sorry that happened, and we'll check into it and make sure it doesn't happen again.
Yeah, that's fine. That's great. If I knew enough tech, I could tell you what the file was. It was just something that it was a file. You click on the file and it wouldn't open.
So
It was
you got
right.
an email. Could you forward that email to me so that we can see what happened there?
Yeah,
Dr.
but
T, it's the ICS file that is a calendar invite. And so you click it and it opens up to a calendar invite. I'm not sure what happened.
It said it said it was going to open to a calendar invite, and I went to every one of my calendars, and none of my calendars were populated with anything. No, that's you're correct. That's exactly it said. This will be a calendar, so I clicked on it, and then I went, okay, I didn't get a calendar invite. Let me go to my calendars and see if we go like with Zoom. It says you got this tentative thing you have to accept. None of my calendars were populated with anything, despite the fact that it said it was a calendar invite. So thank you, Lisa, that's exactly what it was. And so the calendar invite didn't work. Yeah, whoever it was at 6:30 your time, I'm in Central Time Zone right now. But whoever sent that email at 6:30, the bottom of whatever it was a lifesaver. Yeah.
Well, thanks for
Okay,
hanging
guys.
in there that long and
That's a-
joining. Thanks for still joining after that long and all that
That's-
frustration.
It's life. I mean, that's the
Yeah.
tech is far from perfect in 2025.
Yeah. And I know that Nana Jose have been figuring, they're kind of commenting that, they're figuring out what happened. So we
Yeah.
will have what Dr. Terrell said before, we learn from our mistakes and we will
Right.
forget.
Figure it out. We'll figure it out.
It just in my experience, Zoom is the industry leader as far as ease of use. And so having something It's easy to use as Zoom. You get an email that says, here's a link, you click on the link, it opens. I mean, you know, geez. And that would be, and that's what did work in the end for me. So, okay, thanks, guys.
Thank you.
Thank you for letting
Have a
us
nice
know.
evening.
Yeah.
Okay, bye now. Nice meeting you, Dr. Yamaguchi.
Yeah, nice meeting you.
And great. I thought it was great, by the way. I thought it was
Oh,
really
good.
Well, thank you.
Yes.
Thank you.
all right.
All right,
Okay.
everybody. Have a nice evening.
Have
Good
a nice
night.
evening, everybody.